Hi, everybody. Welcome back to another RhAPP FAQ, or Frequently Asked Question. My name is Brandon Coe. I'm a pediatric rheumatology nurse practitioner at the University of New Mexico. I've been doing pediatric rheumatology for about 8 years now. And I'm also on the RhAPP board of directors in the pediatric chair. So today I actually have almost a not frequently enough asked question topic, and something that I don't think we know. I know I didn't get a whole lot of in my training, and is a condition that is an important thing to have on the differential for some of our patients, but is relatively rare and something that is easy to miss. So we're going to do a quick FAQ on hypophosphatasia across the lifespan and some things to look for both in pediatrics and adults, and how to start that evaluation. So hypophosphatasia, or HPP, is a rare kind of inherited metabolic disorder. It's caused by a loss of function mutation in the ALPL gene. And this can result in a variety of tissue impairments, typically in bone and tooth mineralization, but can also have some neurological and other more subtle effects. And so we'll kind of jump into that. In pediatrics, there's a variety of ways this can manifest. There's actually 5 subtypes of HPP in pediatrics. The most severe kind is perinatal HPP. So this is an often lethal and very severe deficiency in that ALPL, or loss of function with that ALPL gene, and often is lethal kind of perinatally. Infantile HPP is the second kind of most severe form, life-threatening presentation. These patients will sometimes have seizures, respiratory problems, failure to thrive, and related to kind of hypercalcemia. Going on from there, the severe childhood HPP presents with rickets, short stature, bowed legs, and motor impairment. So some significant skeletal disease that shows up in our childhood. These presentations, I feel like, are going to be fairly self-evident a lot of the time, and are less likely to end up in our clinic. I want to focus on more some of the mild childhood HPP presentations and some of those adults presentations. So mild childhood HPP has kind of non-specific minor skeletal involvement that can be kind of mineralization issues, bone pain, things like that. And then one of the key findings is like dental problems. Okay. And so you have a premature loss of deciduous teeth. And one of the things to note is this is not just early tooth loss of like kind of childhood teeth, but it's the entire tooth coming out with the root intact. And so that would be kind of a flag that, okay, there's a mineralization issue here that might need to be looked into. There can be an isolated form that just manifests in the premature loss of deciduous teeth called odontohypophosphatasia. But these are the things that present with kind of long bone pain, present with childhood tooth loss, non-specific joint pain that may very well end up in the rheumatology clinic as part of their evaluation. In adults, this can look like things like osteomalacic fractures and osteoarthritis. Again, kind of a history of premature loss of secondary teeth with that root intact. Chondrocalcinosis. And then a key thing for adults is early presentation of pseudogout. And so that kind of crystalline disease, especially under 50 years of age, should raise concern for something like hypophosphatasia. This can even show up in pediatrics, which I can tell you as a pediatric provider, rarely see. And so if you were to have any kind of crystalline kind of pseudogout show up on your pediatric patients after a joint aspiration, that should automatically raise a flag for checking for hypophosphatasia. And so how does one check for this? So the key finding is a persistently low alkaline phosphatase. And that is something that should show up on your routine CMP or hepatic function panel. And so that alkaphos, I feel like it is not something that is focused on quite as much in rheumatology, but keeping an eye on it. If it is low, and this is an age-specific low, so make sure your institution is kind of norming your values for age if you're seeing pediatric patients. But a persistently low alkaline phosphatase is a red flag for considering the diagnosis of HPP. This has to be alkaline phosphatase repeated after 2 to 4 weeks to kind of confirm that persistent low levels there, with consideration for other conditions that can kind of cause a low alkaline phosphatase, like nutritional deficiencies, celiac disease, thyroid disease, Wilson's disease, can all kind of can cause a low alkaline phosphatase as well. But if you find yourself with a patient with a persistently low alkaline phosphatase, make sure to obtain that good medical history, focusing on a history of premature fractures or easy fractures, both in the patient and in the family. Early deciduous tooth loss, to get with that root intact, is a key kind of finding. Non-specific bone pain, family history of early fractures, things like that. And then if that alkaline phosphatase rose persistently low and the history is consistent, there is more specific HPP testing that can go along with. So I hope that was helpful for this kind of rare condition that I feel like we don't ask about often enough, or know to ask about often enough. And for more information on HPP and lots of other rheumatology factoids, information, medications, diseases, and conditions from all across the lifespan, pediatrics to adults, check out the RhAPP website or the RhAPP ACE app. Until next time, take care, everybody.